So what is precision diagnostics? We all know about PSA and its several modifications over the years. People look at PSA density, which is basically related to what your level of PSA is to the volume of the prostate, i.e. how big the prostate is. And one can imagine if you've got a big prostate, you're going to have more PSA production and so on. So you have to correlate both of those parameters and come out with what the PSA density is. PSA velocity and free to total PSA ratios, some people still do, but they're not in everybody's armamentarium in terms of diagnosing prostate cancer. And then there are different types of MRIs. I alluded to the fact that there's multiparametric versus biparametric. I suppose the ideal standard is still multiparametric, whereby you have a contrast injection given to you. And if your hospital does it, please ask for that rather than just a biparametric. But there have been studies such as the PRIME study from University College, which have shown that a well-configured biparametric scan is probably equivalent. And certainly if you're doing a screening trial, then it helps greatly because it's a 10-minute scan versus a 45-minute scan, and it does not require a doctor to give a contrast injection. Biopsies, not straightforward. There's so many different varieties. We all started many, many years ago doing transrectal biopsies, but that really should be confined to the medical dustbin, literally. Most of us feel that transrectal should not be carried out anymore. I wrote a paper on this in 2011, and since then have been doing transperineal, as is now most of the country. And then there's a choice of between general versus local anesthetic. The vast majority of procedures that are carried out in the NHS are local anesthetic. We do all of ours precision biopsies under general anesthetic. And that's because it's really important that the patient does not feel anything, that they're immobilized. So there's no movement going on whilst we're doing the biopsies. Then there's a choice of doing what we call targeted biopsies, which are directed using MRI-ultrasound software, versus what we call systematic biopsies, whereby you just go through the whole prostate and take random biopsies all the way through. Again, more and more of us are moving towards targeted biopsies, although the NICE guidelines still state that we should be doing systematic. One has to have faith in the MRI scan that you've had done. Of course, that's a prerequisite in order to do targeted biopsies. And we're now utilizing MRI ultrasound fusion, not just for diagnosis, but also for treatment. And you may hear of the term cognitive, which basically means that the surgeon or the nurse who is doing the fusion biopsies has looked at the MRI at a distance, said, oh yeah, I can see something up there on the top left-hand corner. I'll try and target something in the top left-hand corner. We go one step further in we're using software fusion, which means that the area of the tumor is configured on the MRI scan digitally by one of our top radiologists and so on. And that is then loaded onto Clever software and brought down to us on the day that we're doing the biopsies. The MRI is then fused real time with the ultrasound scan. So little red areas appear on my screen where the abnormalities on the MRI were. And the reason for that is that, as you'll see from some of my slides later, is that the ultrasound cannot see the same areas as the MRI. Otherwise, we wouldn't need to do an MRI. We'd just be simply doing an ultrasound. So that's what is meant by MRI ultrasound software fusion biopsies. And that leads to precision diagnosis and also to treatment, because then if we've proven that there's cancer there, we can then treat it focally. I'll skip over biomarkers, but they are becoming a little bit more fashionable. And Stockholm 3 is the one that we're doing. What about AI? Barely a talk goes by now in medicine without, AI being introduced in some form or another. AI is already here. There's a UK trial going on at the moment across 15 NHS trusts, whereby it is aiding or augmenting the clinical decision making in terms of MRI readability. And the radiologists are at the forefront of this technology in utilizing AI. There are some MRI scanners which already incorporate AI to try and improve the quality of the actual imaging. And this will only increase. And I think that if a screening program were to come into the UK, that AI would play a major role in sifting out what is normal and then the abnormal to be read by consultant radiologists and so on. So it is being integrated into our prostate cancer pathways as well as other areas of medicine, very, very quickly. This is just a schematic, well, it's a photograph of pictures of me doing some biopsies. Patient is asleep. And as you can see, the white line is the contour of the prostate. The yellow at the bottom of that left-hand picture is where the MRI had suggested that there was a lesion that they wanted us to biopsy. And on the right, there is a red lesion, which implies a little bit higher, potentially higher grade tumor or higher grade of concern, whereby we have superimposed it on the ultrasound over the prostate. The black line in the center is where a catheter lies during the procedure. And you can see that I've only needed to biopsy the areas of concern. So highly accurate recognition of where the abnormality is in the MRI. And then you don't need to go around the rest of the prostate and start willy-nilly sticking needles in. Okay, so this is precision diagnostics and so on. And the beauty of this is that if any of those biopsies showed cancer, we know exactly where it is. And we then utilize those same images to do our treatment and to plan our treatment.